Hundreds of millions of people rely on SSRIs as their daily psychiatric medicine. On the other side, psilocybin has emerged as the investigational challenger. If you are trying to weigh these options, the online discourse is often misleading, framing the choice as a war between traditional pharmaceuticals and a flawless natural cure. The reality is much more grounded. In 2021, a landmark double-blind clinical trial finally put these two specific treatments head-to-head. Robin Carhart-Harris and his team at Imperial College London ran a rigorous trial to measure exactly how these drugs compare in treating moderate to severe depression. We are going to ignore the cultural mystique. By focusing strictly on the clinical trade-offs from this single trial, we can see what these distinct compounds actually do to the human brain. The biological common ground here is that both an SSRI and psilocybin operate entirely through the brain's serotonin system. This diagram shows the serotonin system at the center. They use this exact same chemical network to push the brain in opposing directions. The SSRI pathway is a flat, steady, controlled strategy. It gently raises serotonin levels and keeps them there consistently. The psilocybin pathway is a massive, momentary burst. It relies on a single, intense activation that only lasts a few hours. The core decision hinges on which structural pathway the brain requires most at a given time. The SSRI mechanism is built on accumulation. The drug blocks the pump that normally clears serotonin out, allowing the chemical to continuously bathe your synapses over a period of weeks. Because of that constant load, the brain adapts. Over time, the receptors slowly downregulate and desensitize to handle the chemical volume. This chart plots emotional output, and you can see how this adaptation works. It successfully lowers the volume on crushing depressive lows. But the trade-off is emotional dampening, a flattening of feeling, alongside a high risk of sexual dysfunction. Psilocybin's mechanism works without accumulation. It operates as a massive, single-dose binding event. The active compound forcefully flips open one specific receptor, the 5-HT2A receptor, and hits it hard for just a few hours. That single pulse triggers a rapid burst of neuroplasticity. The brain structurally responds by sprouting new synapses and dendritic connections. Returning to our chart, the result here is an acute emotional opening. The patient is forced to feel deeply connected and confront intense feelings rather than suppressing them. This choice determines the fundamental volume of emotional life, dampening for stability or opening for connection. The second major variable in this decision is the operational tempo and the physical effort required from the patient. The SSRI timeline requires a daily habit. It is a maintenance drug that takes 2 to 6 weeks of continuous use to build baseline efficacy. Psilocybin is an acute, rapid-acting event. Benefits can surface within days following just 1 or 2 clinical sessions. This chart adds input tempo to the equation. The SSRI locks into the daily habit quadrant, while psilocybin sits firmly in the single event space. This dictates the lifestyle requirement. SSRIs offer manageable, at-home maintenance. Psilocybin demands massive, acute clinical effort and dedicated time to integrate the experience afterward. When the Imperial College team tested these opposing mechanisms against each other in patients with moderate to severe depression, they got hard numbers. The trial was evaluated using a pre-registered primary measure for depression, a clinical scoring system called the QIDS-SR16. This bar chart shows the primary depression score drop. On this central measure, the two drugs resulted in a statistical tie. Both groups saw their depression scores improve by roughly equal amounts, but on the secondary measures, psilocybin pulled ahead. As the chart shows, the remission rate for the psilocybin group was 57%, nearly double the 28% seen in the SSRI group. There is a critical caveat to this data. Every single participant in both groups received intensive, expert psychological support throughout the trial. Because of that design, this data cannot tell us how psilocybin performs if a patient takes it alone at home without therapeutic guidance. The data proves psychedelics are a highly potent alternative with fewer sexual and emotional side effects, but it also shows that they do not simply outperform traditional medication by default. Translating this biology and clinical data into a practical decision means looking straight at your personal, financial, and biological constraints. The stabilization seeker needs accessible treatment with long-term safety data, making an SSRI ideal. However, a history of psychosis or bipolar disorder strictly requires this path. Alternatively, the meaning seeker avoids emotional flattening, possessing the time and financial resources necessary for guided therapy. The meaning seeker accepts a specific psychological trade-off. They must be actively willing to confront intense, potentially challenging emotional material. The selection depends on which tool matches a patient's current psychological endurance and financial capacity. If you look at this data and want to make a change, there is a strict medical reality to physically transitioning between these treatments. Abruptly stopping an SSRI causes severe discontinuation effects, and attempting to overlap the two drugs poses theoretical interaction risks. Because chronic SSRI use downregulates your receptors, it blunts the subjective effects of psilocybin. Patients require careful, medically supervised tapering before a session can work. Navigating this choice is a complex medical transition. It requires a prescriber's help to guide your brain safely from a state of steady dampening to a brief, powerful opening.